thank you to the Pipeline Conference organizers for this opportunity to be with you today from the East Coast to discuss this important topic about genetic testing in infants. Who are we finding and who are we missing? I'm just going to request control here from folks. All right, so whenever I give a genetic testing talk, I always like to start out with a reminder about why a genetic diagnosis is so important. When we know a child's genetic diagnosis, this allows for improvements in our ability to prognosticate about the future for the child's family. It enables us to discuss recurrence risk, which offers families important information for family planning. For some genetic etiologies, the diagnosis alters medication choice. But for all etiologies, the diagnosis opens doors for research opportunities so that precision medicine approaches can be possible for the future where they don't already exist today. And finally, a genetic diagnosis opens the doors for connection to other families with the same diagnosis through family foundations and other organizations. These groups, as we have seen, can be tremendous advocates for families and can be important partners in moving clinical trials forward through funding of preclinical research and through collaboration in identifying important clinical outcomes for trials. So what genetic etiologies are we identifying? Well, I borrowed this figure from my colleague Ingo Helbig as it provides a summary of some of the top genetic etiologies identified by the 3 largest next-gen sequencing studies of the past 5 years. If we look at the literature, we find that there are many relevant genetic etiologies in the epilepsies. Our most common genes are, not surprisingly, channelopathies, such as SCN1A, but there are many other familiar names in this list on this slide. I would remind everyone that each diagnosis individually is quite rare. However, when looking at the population in aggregate, genetic testing can identify an etiology in up to 40% of patients, including up to 25% of patients with a normal MRI and otherwise unexplained etiology for their epilepsy. At CHOP, we've established a dedicated epilepsy neurogenetics program, the Epilepsy Neurogenetics Initiative, in order to expand access to genetic testing and precision treatment approaches for patients with epilepsy, and to develop a pipeline for enrollment in clinical research and functional characterization of select ion channel variants. We've done this through a multidisciplinary approach, utilizing providers from multiple specialties who have specific expertise in treating patients with genetic epilepsies. We've been quite successful since our inception, performing more than 2,500 evaluations since the start of FY20 and making more than 250 new genetic diagnoses quickly, with the median time from our first patient visit to a genetic diagnosis of 50 days. Now, critical to our efforts are the approach we've taken to phenotyping our patients. Traditionally, clinical research has focused on chart review and abstraction by research coordinators to establish clinical phenotypes. Now, this introduces unnecessary steps, cost, and delays into clinical research, not to mention problems if the clinical documentation is either incomplete or difficult to interpret. We have focused on obtaining data during routine clinical care using common data element-based EMR tools to both simultaneously capture data and complete required clinical documentation for the physician. This enables detailed patient phenotyping in a high-throughput manner, a sampling of which we reviewed in our recent publication that used these EMR tools to describe the epilepsy phenotype of our cohort. I would argue that generating data during routine clinical care is critical for making sure that we are obtaining both efficiently gathered and accurate phenotypes for our patients' epilepsy and their neurodevelopmental outcomes. So if we look at the genetic diagnoses that we've seen in our program over the past 3 years, we notice that it is remarkably consistent with what one would expect from the large NGS sequencing studies in the literature. A notable exception is the overrepresentation in our cohort of STXBP1, which is really due to specific expertise in our program at the hands of Ingo Helbig and Sarah Ruggiero, who specialize in this particular disorder. Other top genes, however, such as SCN1A, SCN2A, and KCNQ2 are really no surprise. Now, if we focus more specifically on the genetic diagnoses we've made in the infant population, what we see are that the majority of these genetic diagnoses are channelopathies here as well. Not surprisingly, SCN1A leads the pack, but I think it's important to note that there are other common diagnoses, especially in the synaptic genes, and that multiple genes in this cohort either are or could potentially be considered for clinical trials of precision medicine approaches. Now, of course, with all this in mind, how do we really know what we're missing? I think there's several interesting ways to consider this question. This first point seems obvious, I think, but by definition, we miss those patients who are eligible for testing, but who never receive it. I've called this before the "how will this change my management" problem. This approach misses the boat because while a genetic diagnosis may not immediately lead to alterations in clinical management today, not knowing the diagnosis will invariably prevent any future impact to management, as one will be stuck with nothing better than empiric therapy choices for our patients. Now, we can address this problem somewhat with provider education, but this certainly remains an issue despite our best efforts. Now, we also miss patients because of systematic barriers to obtaining testing. The reality is that there is still cost associated with testing, and there is prior authorization and other requirements that must be fulfilled to get testing for our patients. Many insurers are now requiring genetic counseling by a licensed genetic counselor as a prerequisite for being willing to cover testing. These barriers are often too insurmountable for the average child neurologist or epileptologist in private practice. Dedicated genetic programs like ours can address these barriers, but of course, reliance on dedicated programs still leaves bottlenecks that prevent access to testing for many individuals who don't have the advantage of having access to such a specialized program. But perhaps the most interesting way to think about this question is to ask if we are missing opportunities by making diagnoses too late. I think we would all agree that early intervention with a precision therapy, especially in a child with a DEE phenotype, may mean the difference between a poor neurodevelopmental outcome and a global improvement both in seizure frequency and in developmental outcomes. To get at this question, we looked at our own data and specifically looked with an eye towards age at genetic diagnosis for those patients that we did diagnose. Now, this slide demonstrates a ridge plot, and what you can see is the genetic diagnosis on the y-axis and the age at which those patients received their diagnoses on the x-axis. Now, the area under the curve for each gene represents the number of patients with that particular diagnosis. And most importantly, that purple-yellow interface represents the median age at the genetic diagnosis for that particular gene. As you can see, the median age at diagnosis is variable depending on the gene, which would certainly be expected due to the heterogeneity in the age of symptom onset from one gene to another. Overall in our patients, however, we see that most diagnoses are being made either in the infant period or in school-aged children. So if we drill down more specifically on the infants, we can see some important themes. Sorry, we're on a little slide delay, I fear. Here we go. Notably, we're excellent at our center at diagnosing KCNQ2 early, as you can see from the very bottom of that particular graph. We have a median age of diagnosis really of only about 1.5 to 2 months of age. Now, this is partially due to the relative homogeneity within the age of onset of symptoms in this particular genetic disorder. But I think it represents, in many ways, the effort we've invested in educating both our trainees and our faculty about the importance of sending genetic testing early in a neonate with frequent seizures who otherwise does not have an identified etiology for their epilepsy. Now, in contrast, we note that the age of diagnosis lacks months or even years beyond the typical age of symptom onset for a number of other genetic epilepsies in our cohort. So, for example, GRIN2B, SCN1A, SCN8A, STXBP1, and perhaps most notably KCNT1. Now, of course, one might hypothesize a number of reasons for this, including variability in patient phenotype and the age of symptom onset for those particular genetic disorders. However, at least for KCNT1, I can attest that delays here are not related to an abundance of children with an ADNF-LE phenotype, as our cohort is strongly biased towards KCNT1-DEE, which has a much earlier onset. As such, this diagnosis at our center is often being made relatively late in the patient journey, after neurodevelopmental delays and or intellectual disability are already solidly established, which really provides an extra barrier to hoping to have an impact on these parameters with a precision therapy. So how can we make a bigger impact for these children and for their families? I think from a clinical standpoint, the use of common data element-based reporting forms during routine clinical care is going to be exceptionally important, both for the construction of learning health systems and for the understanding of the natural history of a particular genetic epilepsy in the most efficient way possible. This approach has the potential to inform and streamline clinical trial design, as one really does need to know your population before designing a study around it. And from a clinical trial standpoint, enrolling individuals in trials at the right time in the disease course is going to be paramount, if one is going to expect to see significant differences in outcome measures related to neurodevelopmental improvements. This will end up meaning diagnosing patients as early as possible, which remains a struggle even for highly specialized and well-resourced clinical programs like ours in certain circumstances. Looking forward, I think it's critical that we start shifting the focus towards genetic workups as standard of care in children with newly diagnosed epilepsies. This mindset is really the only way to ensure that testing efforts are started early enough to make the maximal difference possible. Now, sponsored testing programs have been a great resource for alleviating some of the systematic barriers to obtaining testing. However, sponsored testing programs do come with the problem of variant interpretation, which ends up in the hands of providers potentially with a very wide array of comfort and knowledge of this process. Finally, having a positive impact on neurodevelopmental outcomes will require early diagnosis and early intervention. Improvements in seizure frequency, while certainly a worthy metric and a good first step in clinical trials, is actually not what really matters most to families. What do I mean? Well, as a final thought, I'll leave you all with this. Stacy Cohen, one of our genetic counselors, recently published a paper on quality of life measures in developmental and epileptic encephalopathies. What she found was in some ways not terribly surprising to me. Quality of life scores in DEEs are actually not at all correlated to what a child's seizure frequency is. However, they are correlated to and related to, as you can see indicated by the orange arrow here on my slide, to the number of days per week that seizures do not impede the child's usual routines. This is a concept that Stacy coined minimally disrupted days. I think it's important that we keep this concept in mind when we're considering how to best evaluate clinical trial outcomes in the future. And with that, I just want to give a big thank you to all the providers and members of our team and the EFA and the Pipeline Conference organizers for this opportunity. Thank you very much.